I want to put you in a very specific, a very uncomfortable moment.
Oh, I think I know the one.
Right. You're in the exam room. You've got this patient, mid-60s, decent health, but their knees are they're just grinding.
Yeah, the classic gray zone patient. We all have a panel full of them.
Exactly. They have that moderate osteoarthritis that isn't quite surgical yet. Maybe they're, trying to avoid the OR entirely,
Yeah.
but it's ruining their tennis game or just making the stairs in their house look like Mount Everest.
And you've already done the responsible thing.
Right. You've maxed out the NSAIDs. They've tried the activity modification. Maybe they've even done a few rounds of physical therapy.
But they've plateaued.
They've plateaued. And they are sitting there in pain, looking at you with that expectation because they know you have a tool in your drawer or rather a needle in the cabinet that can fix this today.
The intra-articular corticosteroid injection. It's really the elephant in the room.
It is. And the instinct is to just do it. I mean, it's quick, the patient leaves happy, and you feel like a hero because you actually did something tangible.
It feels proactive.
Yeah. But looking at the clinical evidence, that reflex, this whole default to the needle, it might actually be working against us. Today, we really need to figure out if adding that corticosteroid is actually providing tangible functional improvement over the next few months, or if we are just, managing optics.
That's the core dilemma for us as clinicians. We are trained to relieve suffering, but the data is starting to draw a very sharp line between feeling better and actually getting better. And when it comes to these injections, those two things might actually be moving in opposite directions over long term. We have to move past this default posture and look at the specific evidence regarding short-term versus long-term efficacy.
So let's play devil's advocate immediately here.
Go for it.
If the patient walks out pain-free, why do we care if it's just a feeling? If I give them a shot and they call me 3 days later saying they walked 18 holes of golf without pain, isn't that a win?
It is a win for that week.
Right.
But what does the data actually say happens after that initial honeymoon period? It's a game of diminishing returns.
Because we know the drop-off is coming.
Exactly. If you look at the efficacy curves, you get this massive, sharp spike in pain relief and functional improvement almost immediately.
Which is the steroid shutting down that inflammatory cascade within the joint capsule.
Right. It's incredibly potent.
And that's exactly what the patient is asking for when they come in.
Sure. But look at the timeline. That curve flattens out really fast. By week 6, the benefit is already waning significantly.
And by week 12.
By week 12, in most comprehensive studies, that line has dropped right back to baseline. You have a moderate confidence in the evidence showing that these benefits just fade. You haven't changed the mechanics of the knee at all.
You've just muted the volume for a couple of months.
A short couple of months. And that's the critical shift in mindset we need to make. There is no sustained long-term improvement. There is zero disease modification happening.
So we aren't buying a cure. We're basically just buying a fiscal quarter.
A very short fiscal quarter. We aren't slowing the arthritis. We aren't regrowing cartilage. We are strictly managing a symptom, and we're doing it for a window that is usually much shorter than most patients realize.
But doesn't that effectively make the injection a placebo with extra steps after month 3? Or is there actually some lingering anti-inflammatory effect we just aren't measuring well?
There really isn't. Once the half-life clears and the local tissue response settles down, the underlying pathology is exactly what it was.
The osteophytes, the joint space narrowing?
The biomechanical faults, yes. It's all still there. The pain returns because the cause of the pain never left. The injection is strictly a selective adjunct for short-term symptom control.
Okay, this brings us to the green light concept. Because we aren't saying never inject.
Absolutely not.
We are saying inject smart. So if we know the window is tight 6 to 12 weeks, who is the actual ideal candidate for this?
This is where we really have to look at baseline pain severity.
Nuance matters here.
It does. The data strongly suggests that patients reporting higher levels of pain at baseline are statistically more prone to experiencing greater short-term relief.
So basically, the worse they feel walking into the clinic, the better the delta.
Generally, yes. Think about it. If the pain is mild, the impact of the steroid might be negligible. It might even be difficult for the patient to perceive against their baseline background noise. But if the pain is significant, that anti-inflammatory blast has a lot more targets. It's a floor-to-ceiling effect.
And we are talking specifically about moderate osteoarthritis here.
Yes, modern disease is the sweet spot. You need enough inflammation to treat, but you also need enough joint structure remaining to actually salvage function.
Right, which brings up a huge point.
Mm.
What happens if we step outside that moderate zone? Like, I'm thinking of the patient with severe bone-on-bone OA. They're terrified of surgery. They're sitting there begging for relief. Why doesn't the steroid work well for them?
Because that is a pathology mismatch. When you have severe OA, the pain is largely mechanical.
It's just bone impacting bone.
Exactly, it's structural collapse. A corticosteroid is an anti-inflammatory chemical. It simply cannot fix a mechanical problem.
You can't chemically buffer a bone spur.
Precisely. You're throwing a bucket of water on a house fire at that point. The disease burden is just too high. The evidence shows that in severe OA, the functional improvement is minimal to non-existent because the mechanical deficit completely overrides the chemical benefit.
Okay, so we have our green light strategy. We offer injections alongside oral analgesics for adults with moderate knee OA, high persistent pain, provided we are aiming strictly for a 6 to 12-week bridge. That seems straightforward enough.
It is if we stick to the rules.
But I want to pivot to the part of the data that actually scares me. The stop signs. The exclusions.
A safety profile.
Yeah, specifically the cartilage issue. We've always known steroids have side effects, skin atrophy, depigmentation, things like that, but we tend to treat the knee joint like it's this isolated, bulletproof vault.
And it is definitely not bulletproof.
Talk to me about the frequent flyer. You know the patient, they come in every 3 months like clockwork for their tune-up. I have colleagues with patients who have been doing this for years. What are we actually doing to their knees?
We might be dissolving the very thing we are trying to save. This is the hard limit we really need to establish in practice. The consensus is firmly shifting to avoiding further injections if the patient has had 3 to 4 in the past year.
Wow, 3 to 4 max. What is the actual biological cost there?
Chondrotoxicity. Corticosteroids can be directly toxic to chondrocytes. Those are the cells that maintain your cartilage.
Right.
And we are seeing concrete evidence from MRI studies showing measurable volume loss in cartilage with frequent injections when compared to saline or placebo.
With volume loss. So the drug we are using to treat the pain of the arthritis is actually accelerating the anatomical progression of the arthritis.
That is the terrible paradox here. In our attempt to delay the need for a total knee replacement by managing their pain, we might be accelerating the exact cartilage degradation that necessitates the surgery in the first place.
That feels like a massive ethical dilemma. How do you square that in the clinic when you're looking at the patient?
You really have to view the injection as a withdrawal from a bank account. You can take a withdrawal to get out of a jam, to get through a vacation, or to tolerate physical therapy for 6 weeks. But if you just keep withdrawing, eventually you bankrupt the joint.
So when that patient comes in for their 5th shot in 14 months and they say, "Doc, it's the only thing that helps," you just have to be the bad guy.
You have to be the honest guy. You have to explain that the help they are feeling right now is coming at the direct cost of their structural integrity. It's a classic case where short-term satisfaction completely masks long-term harm.
Let's expand this risk profile beyond just the knee itself, because we do tend to think of intra-articular injections as entirely local, like what happens in the knee stays in the knee.
Which is physiologically incorrect. The synovium is highly vascularized tissue. That steroid doesn't just sit in the joint space, it gets absorbed systemically.
Meaning we are dosing the whole body.
We are. And for a healthy 30-year-old with a sports injury, maybe that doesn't matter much. But for a 65-year-old diabetic, we see significant glycemic spikes.
How significant are we talking?
Enough to completely disrupt their glycemic control for days. We're talking blood sugars jumping into the 300s or 400s in susceptible patients.
That's substantial.
It is. If you aren't warning your diabetic patients about this or coordinating with their primary care or endocrinologist, you're missing a major adverse effect.
Right.
It requires extreme caution.
And then there's the immunosuppression angle as well.
Right. If a patient is already immunocompromised, maybe they're on biologics for rheumatoid arthritis, or they have other systemic risk factors, introducing a needle and a local immunosuppressant is a prime setup for septic arthritis.
Which is an absolutely catastrophic complication.
It's a joint-destroying complication. So the history taking here cannot just be, does your knee hurt? It has to be a full medical systems review. Diabetes, current medications, infection history.
I want to circle back to something we touched on earlier with the frequent flyer. The psychological aspect of this. There is a quality of life argument that gets thrown around a lot in practice. Patients say, "I just want to be able to play with my grandkids again," or "I want to get my life back."
And as clinicians, that is our kryptonite. We desperately want to give that to them.
But does the data actually support it? Does the injection improve their global quality of life scores?
Surprisingly, no. The evidence is simply insufficient to claim that intra-articular injections improve overall quality of life.
That is a really tough pill to swallow. We can reduce their pain, we can improve their function temporarily, but we aren't changing their global QOL.
It is a critical distinction for our patient counseling. If a patient expects their entire life to turn around because of this one shot, they're going to be disappointed. We are treating a specific symptom in a specific joint for a specific, very short time.
We aren't fixing their life.
Exactly. The pain reduction doesn't always translate to the psychosocial lift that we or the patient hope for.
It goes right back to managing expectations. If you frame it as a short-term bridge, you manage expectations. If you frame it as a fix, you just set the patient up for severe disappointment in month 4.
That's spot on. The consensus is clear. Offer it as an adjunct alongside oral analgesics, provided the goal is strictly limited to that 6 to 12-week window.
Let's talk about the first-line error. I see this a lot. A patient comes in, first visit, knee hurts. They haven't really tried a consistent regimen of NSAIDs. They haven't tried losing weight or modifying activity, but they know about the shot and they want it.
And the path of least resistance for a busy clinician is to just give it to them. But that violates the step care treatment sequence entirely.
Why, though? If we know it works for pain, why make them wait through months of pills and therapy?
Because oral NSAIDs and conservative measures like weight loss and PT have a much safer long-term profile for the joint structure. And more importantly, they address the chronic nature of the disease.
Right. OEA isn't going away.
Exactly. An injection is an event. Osteoarthritis is a lifestyle. You cannot treat a lifestyle disease solely with episodic events.
It's the difference between active and passive coping, isn't it?
Yes, that's a great way to put it. The injection is completely passive. The patient lies on the table and receives relief. PT, weight loss, taking daily medication, those are active. They require the patient to take ownership of their health.
So if you start with the passive treatment, you basically undermine their motivation for the active treatment.
You do. If I give them the shot first, why would they ever go do painful physical therapy?
It won't.
Right, not until the shot wears off. And then they are back to square one, but with slightly less cartilage and a lot more psychological dependence on you and your needle.
Man, that's a profound point. I want to touch on the disease modifier myth again, because I think patients truly believe this. They think inflammation equals damage. Therefore, if you stop the inflammation with a steroid, you are stopping the damage.
It's a very logical leap for a layperson to make, but it is biologically flawed in the context of OA.
Yeah.
In something like rheumatoid arthritis, yes, the inflammation itself drives the joint erosion. But in osteoarthritis, the primary mechanism is wear and tear and mechanical stress.
The inflammation is just a symptom of the structural failure.
Exactly. The inflammation is a result of the damage, not the primary driver.
So treating the smoke doesn't actually put out the fire.
Correct.
Yeah.
Corticosteroids do not alter the course of OA. They do not stop the progression of the disease. The train is still moving down the tracks. You just pull down the blinds so the patient can't see the scenery for a few miles.
What about the dosage trap? I see all kinds of cocktails out there in practice. Clinicians mixing in different local anesthetics, varying the volumes, using different types of long-acting versus short-acting steroids.
That's a major pitfall. Clinicians should not rely on unvalidated dose thresholds or timing intervals that aren't supported by the specific patient context. We really need to stick to standard evidence-based dosing.
More is not necessarily better.
More is definitely not better, and sooner is not safer.
So if we look at the big picture here, we have a patient population that is rapidly aging. Knee-OA is going to become even more ubiquitous than it already is. We need a sustainable strategy.
We absolutely do. And that strategy relies heavily on restraint. It relies on regular reassessment.
The wait-and-see approach.
Yes. Instead of scheduling the next injection automatically, saying, okay, see you in 3 months for your next shot, we should be saying, let's see how you feel in 3 months.
So you tip the patient, not the calendar.
Exactly. If the symptoms haven't returned to a level that truly impairs their function, do not inject.
Yeah.
If the oral medications are working well enough again, do not inject.
It requires a lot more active management and conversation than just setting up a recurring appointment. But it is unequivocally safer for the joint.
It protects the anatomy, and that has to be our primary directive.
Let's synthesize this into a rule we can all take into the clinic tomorrow. If you had to distill this down to a one-line rule, something to put on a sticky note on the computer monitor, what does it say?
In adults with moderate knee OA and persistent pain despite NSAIDs, offer injections for short-term relief unless contraindicated.
Short-term relief, moderate OA, unless contraindicated.
Yes. And avoid expecting long-term benefit. That's the caveat that keeps us honest with ourselves and our patients.
What stands out to you when you look at the disconnect between this clear evidence and what is actually common practice? Why is the gap still so incredibly wide?
I think you consider the human element. The difficulty of saying no or not yet when a patient sitting right in front of you is suffering. It is incredibly hard to look at someone in genuine pain and say, this injection won't help you long term, and it might actually hurt you, so let's stick with the NSAIDs and the PT.
It feels passive to the clinician.
It does. But actually, withholding the needle is the more aggressive, protective move for preserving their joint health.
It's playing the long game.
It is.
Right.
And we so often prioritize the short game because the feedback loop in medicine is immediate. The patient walks out feeling great because of the local anesthetic. They call you 2 days later saying the steroid kicked in and they feel 20 years younger. That is massive positive reinforcement for the provider.
But the negative reinforcement, the accelerated cartilage loss, the advanced need for an arthroplasty, that doesn't show up for years.
Exactly. We don't see the cost of our actions until much, much later.
So let's talk about that initial consultation again. You're sitting there, you've decided they are a valid candidate, they have moderate OA, high baseline pain, no red flags or contraindications. How do you frame the informed consent to set them up for success?
I tell them very directly, this is a tool to get you over a hump. This is going to buy us 6 to 12 weeks of better movement.
Yeah.
And we need to use that time to optimize your physical therapy, to work on weight loss if that's appropriate, to get your daily oral regimen dialed in.
You explicitly tell them it's temporary.
Yes. I tell them this shot is the opening bell, not the knockout punch.
You're using the window of chemical relief to double down on conservative management.
That is the absolute best way to use it. If you just give the shot and send them home to sit on the couch, the pain will come back and nothing will have changed mechanically. But if you give the shot and use that pain-free period to strengthen the quadriceps, to improve their gait biomechanics, now you're actually changing the trajectory of the disease.
That reframes the injection as a facilitator of other treatments, rather than a standalone treatment.
Precisely. It is an adjunct.
Let's touch on the green light strategy again regarding patient preference. What if a patient fits the ideal profile perfectly, but they are hesitant about needles or steroids?
Then you don't push it at all. The evidence is for offering the injection. If a patient prefers to avoid intra-articular injections, that is a perfectly valid, highly evidence-based choice.
You just pivot.
Right. You optimize their oral analgesics.
Yeah.
You optimize conservative care. There is absolutely no mandate to inject just because they qualify.
And conversely, if that patient with severe bone-on-bone OA comes in demanding the shot because their neighbor got one and it worked great.
You have to be the guardrail. You have to explain the pathology mismatch. You explain that the likelihood of success for their specific knee is very low, and the risks of cartilage toxicity and infection are very real. It's about being a steward of their joint.
It's interesting how this all circles back to the clinical definition of success.
It really does. Is success a happy patient today, or a success a functioning native knee in 5 years?
Ideally both.
Ideally. But sometimes in medicine, we end up sacrificing the latter to secure the former.
One thing we haven't touched on deeply is the specific exclusion of inflammatory arthritis. Rheumatoid, psoriatic. Why is that such a hard stop in this context?
Because the pathophysiology is entirely different.
Yeah.
The clinical guidelines we're discussing today are highly specific to osteoarthritis. Inflammatory arthritis requires systemic disease-modifying anti-rheumatic drugs. Shooting local steroids into a joint in those cases can actually mask systemic flares and dangerously delay the appropriate escalation of their systemic therapy.
That makes sense.
Plus, the tissue quality is different in inflammatory joint disease. The risk of joint infection or even spontaneous tendon rupture can be much higher depending on the background medications they're on. It's just a completely different beast.
So stay in your lane. These guidelines are for OA.
Keep it strictly to OA, yes.
Okay, let's quickly summarize the pragmatic workflow for the listeners. Step 1, confirm the diagnosis. We need moderate OA. Step 2, confirm the failure of first-line oral medications.
Step 3, check the history. How many shots have they had in the last year? If it's 3 or more, stop.
Step 4, check for comorbidities, specifically poorly controlled diabetes or systemic immunosuppression.
And step 5, inject for short-term relief, but with a concrete plan for what happens when it wears off.
That is the algorithm. And I feel like step 5 is the most neglected step in modern practice. What is the plan for week 13?
Because week 13 is always coming.
It always does. This has been a really clarifying look at something we literally do every single day. It's kind of amazing how much nuance sits inside a 2-inch needle.
The simplest, most common procedures often carry the most complex decision trees if you actually look at the data.
Before we wrap up, I want to leave everyone with a final thought to chew on. We spent this time talking about the data, the efficacy weeks, the cartilage volume loss. But I want you to think about the psychology of the exam room.
The interaction itself.
Right. If we know the benefit of this injection is effectively gone after 3 months, and we know the risk of permanent joint damage rises with the frequency of these shots, you have to wonder, are we actually treating the patient's pain, or are we just treating our own need to do something in the exam room? Because sometimes the hardest procedure for a clinician to perform is simply keeping your hands in your pockets.